Imagine, just for a moment, being trapped inside a body that simply refuses to follow your instructions.
Yeah, it's a really intense thing to try and picture.
It really is. Like you are sitting in a room, you understand every joke being told, you comprehend the complex conversations happening around you, and you want desperately to join in.
But you physically can't.
Right. Your muscles are so fundamentally out of sync that you can't even form the words to say hello. You can't reach out to grab a cup without your arm betraying you. For most of us, that is a terrifying thought experiment. But for about 706 people currently documented on Earth, this isn't a thought experiment. It is their daily reality.
It is, yeah. It's a profound disconnect between the mind's intent and the body's capability. And it stems from something so impossibly microscopic, it's genuinely hard to fathom the scale of the impact.
If you are listening to this right now, we know exactly why you are here. You are a parent or a carer of a child who has been diagnosed with PURA syndrome.
And you have likely been through a lot to get to this point.
Oh, absolutely. You've probably spent months or maybe even years sitting in these sterile clinical offices, fighting for answers, and just navigating an incredibly overwhelming sea of medical information. It feels like swimming in diagnostic muddy waters where every single answer just leads to 5 more terrifying questions. So welcome to this custom-tailored deep dive.
We are truly honored to be a part of your journey today.
Okay, let's unpack this. Our mission today is highly specific and honestly, a little bit ambitious.
Just a bit.
Yeah, we are taking a massive stack of complex clinical guidelines, cutting-edge genetic research, and intensive therapeutic literature, and we are going to translate all of it into an empowering, completely understandable roadmap for your child's care.
And we really have some incredible sources to work from today.
We do. We're pulling directly from the latest medical journals, including Frontiers in Pediatrics and the American Journal of Medical Genetics. We are dissecting the mandatory surgical guidelines from orphan anesthesia, the expert therapy insights from the Napa Center, and of course, the incredibly vital resources compiled by the PURA Syndrome Foundation.
And, we have to acknowledge that even having this stack of resources represents a monumental shift. I mean, if we were having this conversation just over a decade ago, none of this literature would even exist.
Wait, really? None of it?
None of it. The syndrome didn't even have a name back then.
That is just wild to think about. So to really understand what your child is experiencing every single day, we can't just start with the symptoms. We have to start at the very foundation of their biology. We need to zoom all the way in on a tiny single exon gene located on chromosome 5.
Right. That is the PURA gene. And just to give you a sense of the sheer statistical improbability of this diagnosis, it was only officially discovered and named in 2014.
Which is practically yesterday in medical terms.
Exactly. The incidence rate is currently estimated at about 1 in 1 million. So when you hear that there are only 706 confirmed cases globally as of late 2024, it means your child is quite literally 1 in a million.
It's an incredibly exclusive club that nobody asked to join. So let's get into the mechanics of this. When parents get the genetic testing report back, they are hit with this absolute wall of text.
It's very intimidating.
Yeah, the sources describe the cause as a let me get this right, a heterozygous pathogenic sequence variant on the PURA gene at the 5q31.3 locus. I mean, for a parent reading that on a piece of paper, it just looks like a random Wi-Fi password. Can we break down what that actually means biologically?
We absolutely can. Let's take it piece by piece because it makes a lot of sense once you decode it. First, the 5q31.3 locus. Think of human DNA as a massive library of encyclopedias.
Okay, I'm with you.
The 5 means we are looking at volume 5, or chromosome 5. The Q refers to the long arm of that specific chromosome, and the 31.3 is basically the exact page number and paragraph where this gene lives.
Okay, so we found the exact address in the library. What about heterozygous?
So we all inherit 2 copies of almost every gene, right? One from our mother, one from our father. Heterozygous simply means that out of those 2 copies of the PURA gene, only one of them has a variation.
So the other copy is totally fine?
Yes, the other copy is perfectly standard. Now, pathogenic sequence variant is just the medical way of saying there's a critical typo in the genetic code of that one affected copy. And it's a typo that fundamentally disrupts the instructions the gene is trying to send out.
And the literature notes this is almost always a de novo mutation. That means it wasn't passed down, right? The parents didn't carry this typo.
That is a crucial point for families to hear. Yes, it happened spontaneously during the very, very early stages of embryonic development. There is absolutely nothing a parent did to cause this, and literally nothing they could have done to prevent it. It is just a biological roll of the dice.
I think so many parents carry guilt, so hearing that is huge.
Absolutely. Now, I should add, there's another variation mentioned in the research called a 5q31.3 deletion.
Okay, how does a dilution differ from a variant?
Well, instead of a typo in the gene, a deletion means the entire PURA gene. And often several neighboring genes, like one called NRG2, are completely missing from that stretch of the chromosome.
Oh, wow. So the whole page is torn out of the encyclopedia.
Exactly. And children with this full deletion generally experience a significantly more severe presentation of the syndrome because their bodies are missing the instructions from a whole neighborhood of genes rather than just dealing with one faulty set of instructions.
But for the majority, the gene is there, but there's a typo. And genes are basically just recipes for making proteins, right? So the PURA gene makes something called the pure alpha protein.
Correct. The pure alpha protein is made up of a very specific chain of 322 amino acids. The most common genetic typo we see in PURA syndrome is known as the P-phe23D3 Delaval variant.
Okay, translating again, what does that mean?
To translate that, the 233rd amino acid in that chain, which is supposed to be something called phenylalanine, is just gone. It's skipped over.
It makes me think of baking a cake. You know, you have this complex recipe, and if you leave out just one tiny teaspoon of baking powder, you still have a cake. But the entire physical structure collapses. It doesn't rise. The sources say this single missing amino acid completely warps the three-dimensional physical shape of the pure alpha protein.
That's a great analogy. And the physical shape of a protein dictates entirely how it functions in the body. If it is warped, it cannot lock into the cellular mechanisms it's supposed to operate. Now, to understand the true impact of this, we have to look at what the pure alpha protein actually does.
Right.
It is what we call a highly conserved, multifunctional protein.
Highly conserved, meaning like it hasn't changed much over millions of years of evolution.
Yes, exactly. Nature found a design that worked perfectly and just kept it. It is essential for cellular homeostasis across almost all human tissues. You will find pure alpha operating in your heart, your skeletal muscles, your blood cells. In the nucleus of a cell, it acts like a regulatory supervisor, managing how DNA replicates itself.
Wow, so it's everywhere.
It is. But its most vital, specialized job happens outside the nucleus, in the cytoplasm of our neurons, our brain cells.
The literature says it acts as a transport system for mRNA in the brain. I was really trying to visualize this mechanism. I keep coming back to the idea of the pure alpha protein as an air traffic controller for the developing brain.
Like that.
Yeah, like it's standing out there on the cellular tarmac with those glowing batons, making sure that the specific genetic instructions, the mRNA, land at the exact right synapses at the end of the dendrites.
What's fascinating here is that analogy works on multiple levels. Neurons are incredibly long cells. The instructions for building a memory or forming a new skill are minted in the center of the cell, but they have to be physically transported down the long arms of the neuron, the dendrites, to the translation sites.
It's a huge distance on a cellular scale.
Yes, and the pure alpha protein literally binds to that mRNA, acts as a vehicle, and transports it down the dendrite. Once it arrives, the mRNA is translated into new proteins locally. That local construction is how the brain creates synaptic plasticity. It is the literal biological mechanism of how a human being learns, forms memories, and wires different regions of the brain together.
But I'm struggling to square something here. If this pure alpha protein is so ubiquitous-like, if it's doing work in the heart, the blood, the muscles, why does this mutation primarily result in a neurodevelopmental disorder? I mean, why isn't it causing massive immediate heart failure or muscular dystrophy? Why is the brain taking the brunt of the damage?
It comes down to the concept of cellular vulnerability and the sheer scale of the task. Yes, the protein is everywhere. A muscle cell might be able to limp along and compensate somewhat for a warped pure alpha protein using other cellular pathways. But the brain, especially during fetal development in the first 2 years of life, is undergoing an explosive, unprecedented period of growth. We are talking about trillions of synaptic connections being formed and pruned at lightning speed. It is a highly delicate, heavily orchestrated developmental window.
So the brain's margin for error is basically zero.
Precisely zero. Without that efficient air traffic controller delivering the mRNA precisely when and where it's needed to build those synapses, the neural networks simply cannot wire themselves correctly during that critical window. The heart isn't trying to build trillions of new, adaptable connections every second, but the brain is. That makes the developing neurological system uniquely vulnerable to the absence of functional pure alpha.
That paints a really clear, if, daunting picture. And because the brain's air traffic controller is impaired from the very start, the effects of PRA syndrome don't wait for the child to grow up. They are visible from the very first moments of life.
Yes, immediately.
If you're a parent listening, this next part might bring back some really intense, potentially traumatic memories.
The neonatal period for a child with PURA is almost universally characterized by crisis. The syndrome typically announces itself in the neonatal intensive care unit, the NICU, presenting with a very specific trifold clinical picture.
The literature outlines this triad really clearly. The first pillar is severe central hypotonia. Doctors will often use the term floppy baby syndrome, which always sounds so dismissive to me, given how serious it actually is.
It's a terrible term, frankly.
Right. And the second pillar is respiratory insufficiency, which involves central and obstructive apnea, along with general hypoventilation. And the third is severe feeding difficulties, primarily dysphagia, which means the baby cannot swallow safely and usually requires an esogastric or NG tube, and eventually a surgical G tube right into the stomach.
Alongside that primary triad, neonatologists also frequently observe severe hypothermia, meaning the newborn's body simply cannot regulate its temperature, requiring incubators and warming beds, and also hypersomnolence.
Hypersomnolence meaning they are just excessively unnaturally sleepy.
Beyond just sleepy, they are incredibly difficult to wake up, and even harder to keep awake for basic interactions or feeding attempts. Their neurological system is essentially running in a heavily depressed state.
This is where the diagnostic odyssey officially begins for these families. The doctors see these symptoms, the low tone, the breathing pauses, the feeding failure, and they immediately reach for the diagnoses they are familiar with.
Right, because PRA is so rare.
Exactly. The literature mentions that infants with PURA are constantly initially misdiagnosed as having Prader-Willi syndrome, spinal muscular atrophy, or SMA, or sometimes Rett syndrome. Because PRA is so rare, it often takes years and advanced genetic tests like whole exome sequencing to finally spot that specific typo on chromosome 5.
It is an agonizing period of uncertainty. You are watching your child struggle to breathe, and nobody can tell you exactly why. But neurologically speaking, there are clinical clues that differentiate PRA early on if a specialist knows what to look for. Let's compare it to spinal muscular atrophy, which you mentioned.
Right, SMA is a genetic disease that causes muscle weakness, so it looks similar on the outside.
It looks similar, but the mechanism is entirely different. SMA is a peripheral nerve issue. The anterior horn cells in the spinal cord are actively degrading, meaning the signal from the spine to the muscle is broken. If a neurologist tests a baby with SMA, their deep tendon reflexes, like tapping the knee to get a jerk reaction, are usually completely absent. The wire is cut.
But with PURA syndrome, the muscles themselves and the peripheral nerves connecting to them are structurally fine, right?
Yes. In PURA, the hypotonia originates in the brain. It is central hypotonia. The brain is failing to send the maintained tension signal down the perfectly healthy spinal cord. Therefore, infants with PURA generally retain those deep tendon reflexes.
Oh, interesting.
Yeah, the knee will still jerk when tapped because that specific peripheral reflex arc is intact. That subtle clinical difference is a massive clue that the problem is central, not peripheral.
I want to pause on the respiratory piece for a moment because for a parent sitting by an NICU isolate, hearing the monitor's alarm every time their newborn stops breathing, there is nothing more terrifying. Central apnea means the brain literally forgets to tell the lungs to breathe right.
Yeah.
Does this respiratory crisis last forever?
It is deeply traumatic, and we really have to validate that fear. However, the medical literature offers some of its most significant reassurance right here. The breathing issues are incredibly severe initially, involving long apneic pauses, shallow breathing, and often requiring supplemental oxygen, CPAP, or even full mechanical ventilation. But these specific respiratory crises typically show a trajectory of gradual improvement.
Wait, why does it improve if the underlying genetics don't change?
As the child's brain matures and myelinates over the first year, the brainstem's respiratory control centers seem to stabilize. For most children with PURA, these severe, life-threatening respiratory crises largely resolve after age 1.
That's incredible.
It is. Now, they might still require some monitoring during sleep, or they might be particularly vulnerable when they catch a standard respiratory virus, but that acute, terrifying NICU phase of apnea generally passes.
That is a huge relief to hear. So the breathing often stabilizes as the brainstem matures, but the severe central hypotonia, that pervasive low muscle tone, that doesn't just go away, it persists. And as the child grows, that lack of muscle tension sets off this massive ripple effect that impacts their entire physical and structural development.
This is where the daily lived reality of PURA syndrome really takes shape. The central hypotonia is the primary physical antagonist moving forward. It directly causes profound delays in motor milestones. The texts indicate that a significant majority of affected individuals do not ever attain independent ambulation.
Meaning they don't walk on their own. And for the children who do learn to walk, the timeline is vastly shifted. They typically achieve it between the ages of 3 and 10, and they often have a very wide-based, unsteady gait because their body is constantly fighting gravity without enough baseline muscle tension to keep them stable.
And the inability to walk on a typical timeline doesn't just delay mobility, it triggers an entire orthopedic cascade.
Hmm.
This brings up an incredibly vital point about the mechanics of human bone development.
Oh, this part is fascinating.
Yeah, we are not born with miniature, perfectly formed adult skeletons that just get bigger. Our bones literally require the mechanical stress of gravity and the physical pull of muscles to shape themselves correctly.
Wait, can you explain that? I always just thought bones just grew on their own like fingernails.
Not at all. Bone is dynamic, living tissue that responds to force. Let's take the hip joint, for example. It's a ball and socket joint. When a typically developing infant starts pulling up, standing, and eventually walking, the physical pressure of bearing weight forces the ball of the femur deep into the pelvis. That constant dynamic pressure carves out a deep, secure cup or socket in the pelvic bone over time.
But with central hypotonia, a child with PURA isn't standing at 10 months. They aren't pushing against gravity with that same sustained dynamic force. So they are being denied that essential physical feedback.
Precisely. Without that downward pressure carving out the joint, the hip socket remains shallow. The ball of the femur can easily slip out or dislocate. This condition is known as neuromuscular hip dysplasia. It is a direct mechanical consequence of low muscle tone.
Which means they need constant monitoring.
Yes, it requires very early, proactive orthopedic surveillance.
Yeah.
If pediatricians catch it early enough, it might be managed conservatively with a Pavlik harness, which holds the hips in a spread eagle position to force the ball into the socket.
But the literature shows that conservative management often isn't enough, and these kids require major surgery, things like acetabular osteotomies. What does that actually involve?
An acetabular osteotomy is a major reconstructive surgery. An orthopedic surgeon literally makes cuts into the pelvic bone, the acetabulum, and hinges or rotates the bone over the ball of the femur, securing it with metal pins or screws to manually create that deep cup that the body failed to form on its own.
That is intense, and the spine suffers a similar fate, doesn't it? The scoping review notes that progressive scoliosis is seen in about 48% of PURA patients.
It's the exact same principle. The spine relies on a complex network of core muscles to hold it straight against the constant downward pull of gravity. When those trunk muscles are fundamentally weak due to central hypotonia, the spine begins to collapse and curve.
And if the curve gets bad enough, what happens?
If the curve becomes severe enough that it compresses the lungs or heart, it requires spinal fusion surgery, where rods are attached to the spine to force it straight. Add to all of this the fact that these patients often suffer from low bone mineral density, osteopenia, and chronically low vitamin D, and you have a drastically increased risk of painful bone fractures from very minor trauma.
If you're a parent listening to this cascade of orthopedic risks like hip dysplasia, spinal fusions, low bone density, it is incredibly overwhelming. You might be wondering, how do I stop this? How do I protect my child's skeleton?
And it's a very valid question.
Yeah. And this leads us directly into our core focus for this segment. Because the answer isn't a pill. The answer is highly specialized, intensive physical therapy. But we need to talk about how to actually manage this, especially at home, so that therapy feels like play rather than a grueling chore.
Absolutely. The clinical documentation from the Napa Center outlines some of the incredibly intensive modalities used to combat this hypotonia. They utilize intensive physiotherapy, occupational therapy, and specific techniques like DMI.
Right, DMI stands for Dynamic Movement Intervention. From what I understand, it involves the therapist physically manipulating the child to provoke specific automatic motor responses. Instead of passively stretching them, they are forcing the child's brain to engage the muscles against gravity.
Yes, it's all about active engagement. The Napa resources also mention specialized equipment like the Neurosuit, the spider cage, and Galileo vibration plates.
Okay, let's break those down because they sound like sci-fi devices. What is a spider cage?
The spider cage is essentially a three-sided wire mesh frame. The child wears a specialized belt, and the therapist attaches bungee cords from the belt to various points on the cage. These cords act as artificial muscles.
Oh, that's clever.
Yeah, they can either provide support, taking away some of the child's body weight so they can practice standing without collapsing, or they can provide resistance, forcing the child to push harder to build strength. It allows a child with profound hypotonia to experience upright, dynamic movement safely.
And the Galileo vibration plates. How does standing on a vibrating platform help with the low bone density we talked about?
It works on a cellular level. The Galileo plate oscillates rapidly, tilting back and forth. This microscopic, rapid movement forces the child's muscles to reflexively contract and relax dozens of times per second just to maintain balance.
Wow, just to stay upright.
Exactly. That rapid muscle contraction pulls on the bones.
Yeah.
And remember, bones react to physical stress. That specific frequency of vibration and muscle pull stimulates the osteoblasts, the cells that build new bone, increasing bone mineral density and fighting off that osteopenia.
Along with vital stim for swallowing muscles and serial casting to gently stretch out tight joints over weeks, the clinical side of therapy is just a massive undertaking. But here's the reality for the parents listening. Doing a 3-week intensive at a clinic is amazing. But what happens on a random Tuesday afternoon in your living room?
Right, the daily grind.
Yeah. You can't just drill a tired toddler who has low muscle tone. If it feels like a medical chore, they will fight you and you will both end up frustrated.
Integrating physical therapy into a daily routine is one of the greatest challenges of parenting a medically complex child. The goal is to disguise the work. You have to trick the neurological system into working those muscles by making the environment inherently motivating.
Exactly. Making home physio feel like play.
Let's talk about some specific fun games that build core strength and motor skills, because core strength is the main defense against that scoliosis. Let's say you have a Physio peanut ball, those large peanut-shaped inflatable exercise ball.
Right. Very common therapy tool. Instead of just sitting your child on it and telling them to balance, you straddle them across it so their feet are flat on the floor, and you break out a bottle of bubbles.
Bubbles are incredibly effective for visual tracking and motivation.
Yes, they are magic. You blow the bubbles just slightly out of their reach, slightly above their head or slightly to the side. To reach up and pop that bubble, the child's brain entirely forgets about the fact that it has low muscle tone. It just wants the bubble.
And their body reacts automatically.
Exactly. In order to reach, the child has to automatically engage their deep pelvic and trunk muscles to keep from falling off the peanut ball. You are getting dynamic core engagement, weight bearing through the feet, and crossing the midline, all while they are giggling.
Another highly effective strategy is incorporating unstable surfaces into daily, static play. Say your child loves a specific wooden puzzle. Don't let them do the puzzle sitting slumped on the floor.
Oh, that's a good tip.
Put the puzzle pieces on the couch cushions and have the child stand or tall kneel on the floor to reach them. The couch cushion is soft and unstable. To maintain that tall kneeling position, they have to constantly fire their glutes, their core, and their hip stabilizers. It forces weight bearing through the hips, providing that much-needed pressure to shape the hip socket. But their brain is focused on the puzzle piece, not the physical exertion.
You can make a game out of rolling, too. Rolling is huge for trunk rotators. Set up a tower of soft blocks on one side of the room and have them roll across the carpet like a log to knock it over like a bowling ball. Every single roll forces those core muscles to activate in sequence. It's about finding the joy in movement. Because the reality is children with PURA are going to be in physical therapy for years, if not their entire lives.
Yeah, it's a marathon.
Right. And if you can integrate it into joyous, natural play, it stops being a medical chore and just becomes how you play together.
That perspective shift is essential for the long-term mental health of both the child and the caregiver. Now, if we look at how this central hypotonia impacts the body, it doesn't just stop at the hips or the spine. The exact same pervasive low muscle tone that makes standing or sitting so incredibly difficult also profoundly affects a much smaller but infinitely more complex set of muscles.
You're talking about the muscles of the face, the jaw, the tongue, and the vocal cords.
Yes, the micromusculature required for speech.
Which brings us to one of the most defining and frankly most emotionally complex hallmarks of PURA syndrome, the vast, heartbreaking discrepancy between receptive and expressive language. The communication divide.
This is one of the most consistent findings across all the literature and patient registries. Children with PURA syndrome generally have excellent receptive language.
Meaning what they understand.
Yes, receptive language is what a person can understand. The clinical notes show that these children comprehend complex commands, they follow the flow of conversations around them, and they are highly attuned to emotional cues and humor.
But they are largely non-speaking. The text is very clear that the vast majority of individuals with PRA remain unable to produce meaningful conversational spoken words throughout their entire lives.
And we need to clarify the physiological mechanism behind this,
Yeah.
because it is crucial for how society treats these individuals. This lack of speech is absolutely not a cognitive refusal to speak, nor is it a lack of understanding. It is primarily caused by severe dysarthria and apraxia.
Let's define those. Dysarthria is essentially muscle weakness, right?
Yes. Dysarthria occurs when the central hypotonia makes it physically exhausting or impossible to coordinate the precise, rapid muscle movements of the lips, tongue, vocal cords, and diaphragm required to articulate human speech.
And apraxia.
Apraxia is slightly different to motor planning disorder. The brain knows exactly what word it wants to say, but the neural pathways that sequence the muscle movements to produce that specific sound are jammed.
Man, it is genuinely heartbreaking to imagine having so much to say, like understanding everything that your siblings or your parents are talking about at the dinner table, but being physically trapped behind a wall of low muscle tone and jammed neurological signals. You are locked in. And this is why the literature stresses the absolute, non-negotiable necessity of early augmentative and alternative communication, or AAC.
It truly cannot be overstated. Waiting to see if vocal speech develops before introducing AAC is an outdated and harmful approach.
It's just bad practice.
Very bad practice. AAC is the bridge to the outside world, and it comes in many forms, which can be custom-tailored to the child's specific motor abilities. You have low-tech options, which are highly effective. Keyword sign uses simplified manual gestures paired with spoken words. There are PODD books, pragmatic organization, dynamic display, which are complex binders of symbol-based picture boards that a child can point to.
And then there are the high-tech options, which are just incredible. Tablets and touchscreens with specialized dynamic symbol software where the device actually speaks the words out loud. But what if a child's hypotonia is so severe that they don't have the fine motor control to isolate an index finger to press a button on a screen?
That is where advanced eye gaze technology comes in.
Which is amazing.
It really is.
Eh.
The device uses infrared cameras to track the micro movements of the user's pupils. The child simply has to look at a specific symbol on the screen for a set fraction of a second, and the computer selects it and speaks it. It bypasses the need for gross or fine motor limb control entirely.
The goal of speech therapy here isn't just about forcing the vocal cords to work. It's about treating the dysarthria where possible, sure, but primarily it's about establishing a reliable, robust communication system as early as possible. I want to share a couple of quotes directly from the foundation sources because they really bring this human element to life.
Please do.
There's a quote from the family of a 14-year-old boy named Aiden. They said, "I have learned from Aiden that being nonverbal is not the same thing as not being able to communicate." And then there's Sarah, whose family notes she has great receptive language skills, and she uses a PODD communication book and an electronic device to express herself, and she actively loves using them to interact.
Those quotes highlight a crucial paradigm shift for anyone interacting with a PRA patient. Communication does not equal speech. Intelligence does not equal the ability to vocalize.
But I want to address a very real fear that I hear from parents all the time when therapists suggest a communication device. It's a natural fear. Parents worry, if I give my child an iPad that talks for them, will they just take the easy way out? Will it stop them from trying to develop actual verbal speech? I mean, human nature is to take the path of least resistance. Does the literature back up that fear?
It is an incredibly common concern, and it makes logical sense on the surface. However, decades of clinical research and the specific data on PURA syndrome are unequivocal here. AAC does not hinder speech development. In fact, the dynamic is exactly the opposite.
Really? How so?
Providing a child with a reliable AAC device actually relieves the immense psychological pressure and physical frustration of constantly failing to be understood. The literature highlights a very specific behavioral profile for PURA patients. They are overwhelmingly described as highly social, friendly, empathetic, and affectionate. They desperately want to connect with the people around them.
Right, they're trapped inside, wanting to be part of the joke, wanting to tell you their stomach hurts, wanting to say they love you.
Exactly. When a highly social, cognitively aware child cannot express their basic needs or share their internal world, that frustration compounds rapidly. It often turns inward. It can lead to severe behavioral issues, explosive meltdowns, and even self-injurious behaviors, things like severe hand-biting or head-banging against a wall.
Which is just awful to watch.
It is. It is the physical manifestation of being trapped. AAC provides an immediate release valve for that pressure. It gives them autonomy. By lowering their baseline anxiety and frustration, it actually creates a much more relaxed neurological environment, which makes them more likely to attempt vocalizations without the paralyzing stress of failure.
That is such an important reframe for parents. You aren't giving up on speech, you are giving them their voice today, just in a different format. But communication isn't the only massive neurological hurdle generated by this missing amino acid. The exact same wiring issues in the brain that disrupt motor planning and muscle tone can also lead to literal electrical storms.
Yes, we need to look deeply into the epileptology of PURA syndrome. Epilepsy and complex movement disorders are a massive, often dominant component of this diagnosis.
The numbers in the deep dive sources are sobering. If you are listening to this, you need to know what to look for because epilepsy affects more than 50% of patients with PURA syndrome. It typically rears its head between the ages of 2 and 5, though it can certainly start earlier or later. And it is not just one simple type of seizure.
The epileptic spectrum in PURA is vast and highly volatile. Many patients initially present with myoclonic jerks. These look like sudden, sharp, involuntary muscle twitches or shocks, often happening in clusters, especially when waking up or falling asleep. Over time, as the brain grows, these can evolve into much more severe presentations.
Like what?
This includes generalized tonic-clonic seizures, which involve a sudden loss of consciousness, body stiffening, and violent rhythmic jerking.
Those are the convulsive seizures most people picture when they hear the word epilepsy. But the texts also mention absent seizures.
Yes, absent seizures are far more subtle. The child might just stop what they are doing, stare blankly into space, and completely disconnect from their surroundings for 10 or 20 seconds. It can look like they are just daydreaming, but their brain is actually locked in a widespread electrical misfire.
And in some cases, the epilepsy progresses into something called Lennox-Gastaut syndrome, which is a severe multi-seizure type epileptic encephalopathy. The literature uses a very specific, intimidating phrase to describe PURA-related seizures, notoriously drug-resistant or refractory epilepsy.
It is arguably one of the greatest therapeutic challenges in managing the syndrome. The seizures are incredibly difficult to control with standard anti-epileptic drugs or AEDs. A neurologist might prescribe one medication, it works for a month, and then the seizures break through again.
So what do?
Many children end up on complex cocktails of multiple medications, all of which carry heavy sedative side effects. When pharmacology fails, specialists often have to turn to alternative systemic management strategies.
Like the ketogenic diet, which is mentioned frequently. But how does eating a high-fat, low-carb diet stop an electrical storm in the brain? What's the mechanism?
It's a fascinating metabolic shift, actually. Normally, the brain runs on glucose derived from carbohydrates. When you drastically restrict carbohydrates, the liver begins converting fats into molecules called ketones, which the brain is forced to use as an alternative fuel source.
Okay, so it changes the fuel.
Yes, and running the brain on ketones alters the cellular metabolism and changes the balance of neurotransmitters. Specifically, it appears to increase the synthesis of GABA, which is an inhibitory neurotransmitter. It essentially raises the threshold required for a neuron to misfire, calming the overall electrical excitability of the brain.
That is incredible. And if the diet doesn't work, the sources mention vagus nerve stimulation, or VNS.
VNS involves a surgical procedure to implant a small pacemaker-like device under the skin of the chest. A wire is threaded up to the vagus nerve in the neck. The device sends regular, mild electrical pulses directly into the brainstem.
I always try to picture how this works, and I think of it like putting a pair of high-end noise-canceling headphones on the brain's electrical system. The vagus nerve is like a superhighway into the brain. The device sends this rhythmic, calming electrical hum up the highway, which interrupts and desynchronizes the chaotic noise of a seizure before it can spread.
That is a highly accurate way to visualize it. It breaks the synchronized hyperexcitability.
But here's a question. I know that in some other forms of epilepsy, if the seizures are originating from one specific damaged spot in the brain like scar tissue from a stroke or a small tumor, neurosurgeons can actually go in, do a focal resection, remove that tiny piece of brain tissue, and the seizures completely stop. Why isn't a focal resection an option for a child with PURA?
It all comes back to the blueprint we discussed in Section 1. The PURA mutation is not a localized physical injury. That pathogenic sequence variant, that missing 233rd amino acid, is written into the DNA of every single cell in the child's brain.
Right, because it's a genetic mutation.
Exactly. The entire neural network, billions of neurons, was built using that faulty air traffic controller. Therefore, there is no single damaged hotspot to remove. The threshold for electrical storms is uniformly lowered across the entire global architecture of the brain. Surgery simply cannot fix a genetic baseline like that.
That makes absolute sense, even though it's incredibly frustrating from a treatment perspective. But here is where the daily reality for parents gets really complicated. The sources detail a whole list of non-epileptic movement disorders that also come with PURA.
Yes, it's a very complex picture.
Things like dystonia, which are sustained, painful muscle contractions that cause twisting postures, dyskinesia, which are writhing movements, stereotypies like repetitive hand flapping, and something called a pathological startle response or hyperacusis.
The pathological startle response is fascinating. A child might have an exaggerated full-body, prolonged, jerking reaction to a sudden noise, like a door slamming, or even just an unexpected light touch on the arm. It is actually considered a key diagnostic indicator for PURA syndrome now.
Okay, but put yourself in the shoes of a parent sitting in the living room. Your child's arm suddenly jerks violently. How on earth do you, or even a doctor, tell the difference between a myoclonic seizure, which is an electrical storm that can cause brain damage over time, and a non-epileptic movement, like a severe startle response, which is just a glitch in motor planning and isn't a seizure at all?
You cannot tell just by looking. Even the most experienced pediatric neurologists cannot definitively differentiate them with the naked eye. The physical movements can look identical. This is why the clinical guidelines strongly mandate the critical need for serial EEG and video EEG monitoring.
How does the video EEG untangle them?
By recording the child's physical movements on high-definition video while simultaneously tracking their brain's exact electrical activity with the EEG leads on their scalp. An epileptologist can review the tape, find the exact second the child's arm jerked, and look at the brain waves.
And what are they looking for?
Well, if there is a massive chaotic spike in electrical activity on the EEG at that exact fraction of a second, you know it's a true epileptic seizure. If the EEG remains completely smooth and at its normal baseline pattern during the jerk, it is a non-epileptic movement disorder.
And untangling those two things is vital because you treat them entirely differently, right?
Completely differently. Anti-epileptic drugs are heavy-duty. They cause sedation, cognitive dulling, and liver strain. You absolutely do not want to heavily medicate a child with toxic anti-seizure drugs to try and stop what is actually just a benign startle reflex. The drugs won't work on a reflex, and you'll just be exposing the child to side effects.
The precision required in this medical management is just staggering. Now, because of these refractory seizures or the severe orthopedic issues like hip dysplasia and scoliosis or the feeding difficulties requiring the placement of a G-tube, the statistical reality is that your child will likely require surgery at some point. And this brings us to a section of our deep dive where we have to issue a massive flashing warning label to every parent listening.
This is arguably the most critical piece of immediate life-saving medical advocacy for any PURA family, the operating room.
General anesthesia carries incredibly high specific risks for patients with PURA syndrome. The sources provide peer-reviewed guidelines from a specialized body called Orphan Anesthesia, and these are mandatory reading. If your child is scheduled for any procedure, you literally need to print these guidelines out, highlight them, and hand them directly to the anesthesiologist during the pre-op consult.
You cannot assume they know this information. Because PURA is a 1 in a million condition, the statistical odds are that the anesthesiologist at your local hospital has never, in their entire career, met a patient with this syndrome. They will treat them like a standard pediatric patient with low tone, which can be catastrophic.
I am struggling to understand just how risky this is. Let's walk through the specific warnings in the guidelines. First, extreme sensitivity to sedatives.
The guidelines explicitly dictate that the standard dosages of opioids like fentanyl or morphine and benzodiazepines like midazolam must be reduced by approximately 50% for a PURA patient.
Why? What is the mechanism there? If they are so sensitive, how does an anesthesiologist keep them safely unconscious during a major painful spinal fusion? That sounds like an impossible tightrope to walk.
It is a tightrope, yeah. The reason for the sensitivity goes back to the central hypotonia in the brainstem. The brains of PURA patients are highly sensitive to respiratory depressants. Their baseline drive to breathe is already compromised.
Because of the apnea we talked about earlier.
Exactly. So if an anesthesiologist gives a standard weight-based dose of an opioid, it could suppress the child's respiratory drive so profoundly that they simply stop trying to breathe for dangerously long periods even after the surgery is over. The anesthesiologist has to use alternative, shorter-acting agents and regional nerve blocks to manage pain without shutting down the brainstem.
Okay, second major risk, severe hypothermia in the OR. We mentioned earlier that they have trouble regulating body temperature as newborns. Why does this become critical on the operating table?
Operating rooms are kept very cold to reduce bacterial growth. When a patient is under anesthesia, their body loses the ability to shiver to generate heat. Because a PURA patient already has a compromised autonomic system, their core temperature can plummet rapidly in the OR. They require active, aggressive warming measures.
Like what kind of measures?
Things like forced air warming blankets and warmed 5E fluids the entire time they are in the room, or they risk cardiac arrhythmias from the cold.
And the third major risk is aspiration. This links directly back to the central hypotonia we've been talking about, right?
Yes, aspiration pneumonia is a leading cause of severe illness here. Because the muscles of the pharynx, the throat, and the airway lack normal resting tone, they are incredibly floppy. When a patient is waking up from anesthesia and the breathing tube is removed, a typical airway stays rigid and open. A PURA patient's airway is highly prone to simply collapsing shut.
And if that happens?
If that happens and any fluid from the stomach travels up, it can easily enter the lungs.
So how does the team prevent that?
The orphan anesthesia guidelines strongly recommend the use of prophylactic nasopharyngeal airways. This is essentially a soft, flexible tube inserted through the nose and down into the upper throat. It acts as a physical stent, keeping the floppy airway held open mechanically during the entire high-risk recovery and awakening phase.
Because of all these compounding respiratory, apnea, and airway risks, the post-op protocol is extremely strict. The guidelines clearly state that ambulatory surgery, what we commonly call day surgery, where you get your tonsils out or a tooth pulled and go home that same afternoon, is entirely contraindicated for PURA patients.
Absolutely contraindicated. No matter how minor the procedure is, they require a minimum of 24-hour continuous inpatient monitoring on a ward with continuous pulse oximetry to ensure they don't experience delayed apnea and stop breathing in their sleep, as the anesthetic drugs slowly metabolize out of their fat stores.
And we can't forget the epilepsy during all of this. If a child is NPO, meaning nothing by mouth, fasting for 12 hours before surgery, they obviously can't swallow their morning dose of seizure pills.
And skipping a dose of antiepileptics in a patient with refractory epilepsy is a recipe for a perioperative seizure storm. The anesthesiologist must be prepared to maintain those antiepileptic drugs intravenously throughout the entire fasting period during the surgery itself and into the recovery phase until the child can safely take medications by their G-tube or mouths again.
If you are a parent, you have to be the ultimate gatekeeper here. You are the undisputed expert on your child, and it is entirely okay to be the loudest voice in that pre-op room. But looking at all of this, something really stands out to me. We are talking about hypothermia in the operating room, where the body can't regulate heat. And earlier, the literature touched on chronic severe constipation at home, which it says is a near universal complaint. It seems like the body's automatic background systems are just fundamentally glitchy.
That is a very astute biological observation, and it points to a wider issue: autonomic nervous system dysfunction. The autonomic nervous system is the background operating software of the human body. It controls all the vital things you never consciously think about: your heart rate, your baseline body temperature, your pupil dilation, and your intestinal motility.
So because that para-alpha protein is missing in the brainstem and the autonomic ganglia, that background software is corrupt.
Exactly. That is the unifying mechanism. That's why they can't regulate their core temperature under anesthesia. And it's why the smooth muscles lining their intestines don't automatically contract in a coordinated ways called peristalsis to push waste through.
So the gut is just hypotonic too.
Yes, that lack of gut motility leads to severe chronic constipation that cannot be fixed by just eating more fiber. It usually requires daily osmotic laxatives.
Let's define that quickly. How does an osmotic laxative differ from a standard stimulant laxative?
A stimulant laxative tries to force the intestinal muscles to squeeze, but in PURA, those muscles are hypertonic. They don't squeeze well. An osmotic laxative, like Miralax, works via chemistry. It draws water from the surrounding tissues directly into the colon, softening the stool and creating bulk that gravity and minimal muscle action can easily pass. It bypasses the need for strong muscle contractions.
Wow, it really is everywhere.
It proves just how truly multisystemic this genetic syndrome is. We also see systemic issues in ophthalmology, with high rates of strabismus, which is a misalignment of the eyes where they don't track together, and endocrinology issues like precocious or severely delayed puberty.
So, keeping a child with PURA healthy means actively managing their orthopedics to prevent spine collapse, monitoring video EEGs for hidden seizures, doing intensive daily therapies disguised as living room games, navigating highly dangerous surgeries, and managing their daily gut chemistry. Surviving the OR and the daily exhausting grind of therapies is a marathon for these families. It requires relentless energy. But as we turn to the final section of our deep dive, all of this hard work, all this advocacy is leading toward a surprisingly optimistic horizon as we look to the scientific future.
We are entering an era of unprecedented research and genuine mechanistic hope for PURA syndrome. But before we get to the labs, let's talk about the natural history of the disorder as a child grows. What does the future actually look like for these kids?
The most important, comforting thing to emphasize from all the clinical data: PURA is not a degenerative disease.
That is a crucial distinction. In many neurogenetic conditions, children acquire skills and then tragically lose them. In PURA, patients do not lose the skills they have fought so hard to acquire. They make progress. It is undeniably slow progress, and they will remain globally delayed compared to their peers, but the trajectory is consistently forward, not backward.
And they survive well into adulthood. The Foundation registries have identified patients thriving in their 30s, 40s, and 50s. They require 24/7 care for their activities of daily living and their complex medical needs, but they live long, full lives. This means transition planning is absolutely vital.
It really is.
The sources suggest starting this process around age 12 to handle the complex legal transition to adult guardianship, finding appropriate adult day programs, and the incredibly difficult process of moving from pediatric specialists who are used to rare diseases to adult specialists who often are not.
And their quality of life, their behavioral profile, is a defining part of this adulthood. As we mentioned with the communication devices, the literature repeatedly describes individuals with PURA as overwhelmingly loving, highly social, and friendly. Their fundamental disposition is eager for human connection.
The literature does note they can experience significant anxiety, but it points out this is often driven by sensory overload or unexpected changes in routine, which is totally understandable given how hard their nervous system is working just to process the basic stimuli of the world.
But the real focus of the future is on what the global scientific community is actively doing to address the root cause of this syndrome. And the research pipeline from 2024 to 2026 is moving at a breakneck pace.
Let's talk about the mice. This is where the science gets really tangible. In May 2025, the Jackson Laboratory, which is a massive genetic research facility partnering with a parent-led nonprofit called Jack's Tomorrow, achieved a massive milestone. They developed a CRISPR-Cas9 knockout mouse model.
In the world of rare disease research, having an animal model that accurately mirrors the human condition is the single biggest bottleneck. Without it, you are basically stalled. You cannot test experimental drugs safely on humans without testing them on animals first.
So how did they do it?
By using the CRISPR gene editing tool to literally knock out or break the specific PURA gene in these laboratory mice, scientists created a living model that exhibits the exact same fatal seizures, the same hypotonia, and the same severe motor deficits we see in human children.
And now that they have this biological sandbox, institutions across the globe, like the Florey Institute and the Murdoch Children's Research Institute in Australia, are using those mice alongside human patient skin cells to test real therapies. The literature talks about two main paths. First is drug repurposing.
Drug repurposing is the fastest path to the clinic. Researchers use high-throughput screening to test thousands of existing FDA-approved drugs like drugs meant for blood pressure or cancer to see if any of them accidentally fix the specific biological pathways causing the drug-resistant epilepsy in the PURA mice.
Oh, because they're already approved.
Exactly. If they find one, it can be given to patients almost immediately because its safety profile is already known.
But the real holy grail they're chasing, the thing that could change the foundational biology, is gene therapy. Specifically, the sources highlight gene overexpression therapies. Okay, let's unpack this. Does this mean a definitive cure is coming tomorrow?
We have to ground the excitement in scientific reality. It does not mean a cure is coming tomorrow. Human gene therapy is infinitely complex, especially when trying to deliver it to billions of neurons in a living brain. But the specific mechanism they are focusing on overexpression is brilliant in its elegance.
How does overexpression work?
Remember our genetic blueprint. PURA patients are heterozygous. They have one broken copy of the gene producing a warped protein, but they also have one perfectly healthy copy producing normal pure alpha protein. The problem is simply a lack of volume. One copy can't produce enough to meet the brain's massive demand.
So they just need more of it.
Yes. Overexpression therapy uses a viral vector, essentially a hollowed-out virus, to deliver specialized genetic instructions into the brain cells. These instructions don't try to fix the broken gene. Instead, they act like an amplifier, telling the one healthy copy to work overtime, to dramatically overexpress itself and produce double the amount of normal poor alpha protein, compensating entirely for the broken copy.
That is absolutely mind-blowing. They just turn up the volume on the good gene. And the regulatory landscape, the legal rules governing how these drugs get to patients, just shifted dramatically in favor of this exact science. In February 2026, the FDA issued updated draft guidance specifically for targeted therapies in ultra-rare diseases.
This cannot be overstated. This FDA guidance is a total game changer for the rare disease community. Historically, the FDA required massive, randomized, double-blind clinical trials with thousands of patients to prove a drug was effective before they would approve it. If your disease only has 706 patients scattered across the entire globe, running a trial like that is mathematically impossible. Rare diseases were stuck in a regulatory dead end.
But the new 2026 guidance changes the rules of the game. It allows for approval based on a plausible mechanism of action.
Exactly. The FDA is saying if you can prove to us in a lab, using those exact knockout mouse models and actual human patient cells, that this genetic therapy reliably fixes the cellular defect and is fundamentally safe, we will allow you to bypass the massive human trials and expedite approval. It removes the statistical barrier to entry.
But how did those scientists get those exact human patient cells to test on? How did they prove the mechanism? This is where we bring the entire story right back to you, the listener.
It all comes down to patient advocacy. Specifically, the relentless work behind the PURA Syndrome Foundation's Global Patient Registry and Biobank.
Right. Because science doesn't happen in a vacuum. Without families undergoing the stress of donating skin biopsies, coordinating blood sample shipments, and painstakingly entering their child's lifetime of medical data into that registry, researchers wouldn't have the physical materials they need to test these therapies. The FDA's plausible mechanism pathway couldn't be utilized because there would be no human cells to prove it on.
They are the foundation of everything.
If you are listening to this, you are not just a caregiver managing daily hypotonia. By participating in these registries, you are literally the engine driving the global science forward.
It is the ultimate symbiotic partnership. The families provide the biological raw materials and the funding, and the scientific community provides the specialized labor to build a cure. Neither can exist without the other.
So as we close, let's summarize the immense journey we've unpacked today. PURA syndrome is a profoundly complex, multisystemic neurodevelopmental disorder. It stems from the absence of a single functional protein, the PUR alpha protein, which acts as that vital air traffic controller for mRNA in the developing brain. That missing controller leads to severe neonatal crises in the NICU, persistent central hypertonia that alters bone development, massive expressive communication hurdles, and often severe drug-resistant epilepsy.
It is a very heavy diagnosis. But we also know definitively that with intensive play-based physical therapies like we discussed, with the immediate early implementation of AAC to give these highly social children a voice, with incredibly precise medical surveillance, especially when navigating anesthesia and orthopedic risks, patients do not degenerate. They make slow, steady, hard-won progress. They live deeply connected, meaningful, and incredibly loving lives.
And the scientific horizon is brighter right now than it has ever been in history. But before we sign off, I want to leave you with one final provocative thought. A mind-expanding idea drawn directly from the deepest, most complex layers of the genetic research in our stack of sources today.
It's an idea about how everything in human biology is ultimately connected, and how the ultra-rare might hold the key to the incredibly common.
Exactly. We've spent this whole time talking about how the pure alpha protein is the singular key to PURA syndrome. But researchers have discovered something astonishing. This exact same protein does not exist in isolation. It actively interacts with the expanded genetic repeats that cause amyotrophic lateral sclerosis ALS, commonly known as Lou Gehrig's disease, as well as the genetics behind Fragile X syndrome. These are some of the most devastating, common, and well-funded neurodegenerative diseases on the planet.
The broader scientific implications of that biological interaction are just staggering.
It raises an incredible question. What if, by pouring resources into studying the biology of the rare, beautiful children with PURA syndrome, science eventually unlocks the fundamental key to understanding and curing ALS? What if your child's incredibly rare, difficult, one in a million medical journey is actually the biological Rosetta Stone needed to spark a global medical revolution?
It completely changes the narrative of the diagnosis. It means these children aren't just rare patients to be managed. They are absolute pioneers at the very frontier of human genetics.
We started this deep dive talking about the comfort of a clean x-ray, a simple, visible, broken bone that is easy to fix. PURA syndrome is not clean x-ray. It is murky. It is a daily, exhausting swim through diagnostic muddy waters. But we hope that by mapping the biology, by outlining the mechanics of the therapies, and by highlighting the massive, tangible hope on the scientific horizon, we've helped clear the water just a little bit for you today. If you are managing this day to day, you are doing incredible, vital work. Keep advocating for your child in the OR, keep playing those games on the peanut ball, and keep pushing the science forward. We'll see you next time on the Deep Dive.